Good morning, everyone. My name is Dipanshu Kaushik, and today I'm going to present my seminar on the topic diagnosis of pseudoseizure and difference between seizure and pseudoseizure. My moderator is Dr. Ayushi Gera. So let's start first with what are seizures. Seizures are defined as a occurrence of sign and symptoms due to abnormal excessive neural activity in the brain, which may be recorded in the EEG. Then comes the term epilepsy. Epilepsy is two or more unprovoked seizure without any cause leading to clinical symptom. Now, pseudoseizure. Pseudoseizure is an older term for events that appear to be epileptic seizures, but in fact do not represent the manifestation of abnormal excessive neuronal activity in the brain, which define the epileptic seizure. Current standard terminology for this type of events are psychogenic non-epileptic seizures, or PNES. They are not a variation of epilepsy, but are of psychiatric origin rather than organic cause. Now, risk factor for PNES are, they are more commonly seen in women. Chances of PNES are more higher in younger adults, and there is chances of PNS are also higher if there is history of injury or disease. Some severe emotional upset or stressful events in life, like someone is going through a divorce, can also precipitate PNES. Now, patients with psychiatric conditions like depression, anxiety, and personality disorders may also complain of PNES. Another important factor which may lead to diagnosis of PNES are history of sexual or any physical abuse. So what factors may precipitate PNES? These are like some accidents, severe emotional upset, psychological stress such as divorce, and physical or sexual abuse, or if someone is being bullied. Now, common symptoms of PNES are side-to-side shaking of the head, which is not seen in normal epileptic attacks, bilateral asynchronous movements, like example like bicycling, leg movements, pelvic thrust, weeping, stuttering, and arching of the back, preserved awareness, eye flutter. Episodes are affected by bystander. Means if a person is feigning some seizure, episodes of seizure may be elevated if the person is standing to someone else, or it may be depressed as well if another person is standing next to it. Now, as these seizures are currently, according to ICD, are diagnosed under dissociative convulsion. So according to ICD-10, the diagnostic criteria of dissociative convulsion include there is no tongue bite, no serious bruising due to falling, no urinary continence, and no loss of consciousness. There is no evidence of physical disorder that explains the symptoms. Association in time between the onset of symptom and stressful event or problem is there. Now, DSM-5 diagnostic criteria for pseudoseizure. Pseudoseizure in DSM-5 are categorized under somatic symptoms and related disorders and are defined as functional neurological symptom disorder. Now, diagnostic criteria according to DSM-5 includes one or more symptom of altered motor or sensory function. Clinical findings provide evidence of incompatibility between symptoms and recognized neurological or medical condition. The symptoms of deficit is not better explained by another medical or mental disorder. The symptoms or deficit caused are clinically significant distress or impairment in social, occupational, or other important areas of function. Now, how to differentiate between PNES and epileptic seizures. So first, there is a precipitating factor which is present in PNES, which are emotional and stress related. But in epileptic seizures, there is rarely any precipitating factor. When the person is sleeping or is alone, epileptic seizures can be seen, which are common during that period. But PNES is not commonly reported during that period. Onset of epileptic seizures is usually short, but in PNES, it may be short or it may last over several minutes. Various stereotypical auras are seen in epileptic seizures, but in PNES, fear and panic are most common. Then movements in epileptic seizures, there are movements like atonic, tonic, clonic, or myoclonic jerks are seen. In PNES, asynchronous flailing of the limbs, pelvic thrusting, side-to-side bobbing of the head is seen. Injury after epileptic seizure, there is commonly, which is seen, is tongue biting. Directed violence towards someone is rare in these type of seizures. But in PNES, there may be tongue bite, throwing of hands, and directed violence may be present towards somebody. Consciousness is lost in epileptic seizures, like complete loss in GTCS, and it may be incomplete in some seizures like partial seizures. But in PNES, there is variable and inconsistency in loss of consciousness with seizure type. Now, response to stimulation in epileptic seizures, there is no response to the stimulation. But in PNES, there is the patient often reacts, and this may terminate this episode. Urinary incontinence is common in epileptic seizures, but it may be rarely seen in PNES. Duration is of few seconds to minutes in epileptic seizure, and it may be few minutes and may be prolonged in PNES. Recovery is prolonged in epileptic seizures, as there is something which we call post-ictal period, which is seen in epileptic seizures. But PNES recovery is rapid and rarely post-ictal symptoms are seen. Now, these are the differences. On the left hand side, we can see the PNES, and on the right hand side, there is epileptic seizure. As we can see in PNES, person is moving his whole of the body. Trunk is moving, pelvic thrusting is seen, and hand movements are not corresponding to the seizure. But here on the right hand side, person is going under the attack of GTCS. Here we can see tonic attacks of the GT. Now, to reach a diagnosis of PNES, first we have to know other condition which we have to rule out. So differential diagnosis of PNES are which can be neurological, metabolic, cardiological, or pulmonary. Neurological conditions include epilepsy, migraine, dystonia, tic, myoclonus, transient ischemic attack, tonic spasms of multiple sclerosis. Metabolic disorders like hypoglycemia, hypocalcemia, drug use and abuse can also precipitate seizure. Now, cardiological and pulmonary conditions like vasovagal syndrome, arrhythmia, and pulmonary hypertension or outflow obstruction can also lead to seizure precipitation. So, arriving at the diagnosis of PNS in a clinical condition, first we have to know that PNS is majorly a diagnosis of exclusion. History taking and examination is foremost important in these cases. Especially look for conversion disorder, somatization disorder, past history of depressive episode, history of physical or sexual. Various biochemistry test imaging studies to be performed to rule out the epileptic seizures. Then one feature which is common in epileptic seizure is prolactin levels, which increase by 2 to 3 times when measured within 10 to 10 minutes of seizure, suggest presence of epileptic seizure, and this feature may be absent in PNES. EEG study, routine EEG is not helpful in diagnosis of PNES, but video EEG monitoring is the standard for diagnosis. Now, video EEG, the principal main here is to record an episode and demonstrate that no change in EEG occurs during the clinical event. Repeated normal EEG findings, which are routine EEG findings, and resistance to anti-epileptic drugs are suggestive of PNES. Another way of diagnosis of PNES are through inductions. Provocative techniques, activation procedure, or inductions can be extremely useful for diagnosis of PNES, particularly when the diagnosis is uncertain and no spontaneous episodes occur during monitoring. Treatment is through psychotherapy, treatment of coexisting anxiety or depression, combination of anti-epileptic drugs and psychological treatment for a patient if he is having both epileptic as well as psychogenic seizures. Then there is patient education and family education. So these were my references.